Welcome everyone. My name is Johnny McGlaughn. I'm your consultant pharmacist. I'm making a video of my MedPass in-service so that the nursing staff can let you at your convenience watch it. Due to COVID regulations now, we're not supposed to get together in large groups, as all of you know. So I'm going to video this and y'all can watch this video as an in-service at your convenience, and the DON can use it at her discretion for orientation for all new hires. So with that, I'll crank off, and hopefully that the nursing staff has given you an outline. You can follow me. If you have any directions, questions, or anything like that, then you just write them down and then get with your DON and she'll contact me, and we'll answer your questions to the best of our ability. The first two areas I want to cover is the two areas that surveyors have cited the regulations at the nursing homes with, and that is number one is in infectious control, number two is in privacy issues. So I want to go over them first, and then I'll go over in more detail the exact MedPass procedure. The privacy issues first. Privacy issues deal with you keeping the information of the resident totally private. That includes hiding of the electronic MAR, which I know it's supposed to go off in so many seconds, but do not leave that EMAR on the cart unless you see that screen be hidden. And then if you are not a member of the modern times and dealing with the electronic EMARs, then you have the written MARs, computer generated MARs, so you have to have a cover sheet to cover those or close your MAR totally. Second area in privacy is knocking. And I didn't know this until a year and a half ago, but you are required, when the door is closed, to knock and announce yourself, and you have to knock at least 3 times. After 3 times, you open the door slowly and announce yourself and tell the resident who you are and the purpose for which you're there. The second area is in privacy curtains, okay? And the last area is total privacy. Total privacy only occurs when you have the door closed, the privacy curtain pulled between 2 beds, and the blinds or the curtains closed. Now I know the third area is a little picky, and if a resident has flower pots or pictures or little trinkets that the family has shared with them, you ask them the exact question: do you care, if I close these blinds or pull your curtains? And if they say no, then leave it alone. That's their private stuff and they have a right to it. Okay, infectious control is the second most cited area by the state surveys, and that is involved, of course, with washing of the hands. Between every resident you go and administer meds to, you must either use one of the two, either use alcohol sanitizer, or you must wash your hands for the required seconds, and then you follow that up, as deemed necessary. But you must do one of those two in between every resident. All right, there are 5 times at which you are required to wash your hands, okay? And that is anytime you have direct contact with a resident or an inanimate object in the room. Inanimate objects include the bedside tables, the privacy curtains, movement of any other object in that room, rolling of the bed up, to help them, have a better angle at swallowing the medications. All of those are inanimate objects. And if you touch something, you must wash your hands with soap and water before moving on to another resident, because that person has sneezed, coughed, etc., and touched, and their germs are on, like the privacy curtains and those other personal items. So you must wash with soap and water before you move on. The alcohol gel, I learned this also a year and a half ago when I talked to the Alabama Department of Public Health, how many times it's allowed to use alcohol gel without washing your hands, and the answer to that is 3 also. You're allowed to use the alcohol gel, but after 3 times, you must, wash your hands with soap and water, because the stickiness of the hand sanitizer builds up around your fingers, and you need to wash with soap and water. And avoid contamination of any equipment that you're using to take care of that resident. Okay, now we're going to move on to the topic of the major parts of the drug pass. MedPass procedures. When you start, you make sure you have all your equipment, you're ready to go, and don't tell history of things that the resident's about to do or don't do. You just share 5 things and 5 things only with the surveyor. Okay, that resident's name, the name of that drug, the strength of that drug, how many doses you're given, and what you're giving it to them for. And let them see the medication card or the box that medication comes from so that they can see it. And if they nod their head, you move on. First topic in that part of the MedPass procedures is how to handle missed doses or unavailable doses. And both of these are handled in the same manner. First, the missed doses. If you're administering the medications to your residents and the surveyor's watching you and you forget for some reason to give something, maybe an over-the-counter product, and you remember it before the time frame is up, then you go get that surveyor and tell them. If for some reason you're out of your time compliance of 1 hour prior to and an hour after the time of that dose, then you call the doctor on the phone, you get a new order for that time medicine to be given at that time and that time only, and you write it on there as a verbal order and fix it where the doctor can sign that's his next visit, and they cannot cite us for out of time compliance. How to handle unavailable doses. If you get to something and it's not there, you call timeout, you go get your immediate supervisor, and then you tell them what the situation is. Then you continue with your MedPass. In the meantime, that immediate supervisor gets on the phone, calls the backup pharmacy, tells them the surveyors are there observing these medications to be given, and you get them there ASAP. And as soon as they're there, if the surveyor has stopped watching you, you go get them and tell them that medicine has arrived and you're still in time compliance, so do they want to watch it? Most of the time they're going to say no, but make sure you see them scratch it out off of their little list of do's and don'ts. Next topic on the MedPass procedure is the crushing of medications. Now, if you've just got a little medicine cup full of medications for oral use only, and you're not touching anything, that I mentioned in the 5 aspects that require hand washing with soap and water, then it's okay to hand that cup to that medicine, observe them follow that medicine into their mouth, follow it with water, and observe them swallowing it, and ask them to see their open mouth to make sure they've swallowed them. Crushing of medications and opening of capsules. Okay, if you have a medication that is to be crushed and they can't swallow that particular medication, you must put on gloves to open those capsules and then put them in the med cup. And if you're putting them on top of applesauce to make it easier to swallow, you must make a little volcano top in the top of the applesauce and put that medication directly in there, and do not mix it up too thoroughly, and just take your spoon and scoop it up under there. That way you won't get it stuck to the sides of the med cup and then we get tagged for inadequate dosage. Liquids, when to shake, when not to shake. It's okay to shake any liquid except one, and that's Colace. Colace liquid is a soap molecule based, used as a stew softener, we all know. And if you shake it, then you're going to get a little foam on it that's like a foam on a head of a beer, and it doesn't dissipate rapidly enough, and it'll ooze down the sides and get the bottle sticky. So never shake Colace liquid. Every other liquid it's okay to shake. Suspensions you must shake, and shake them vigorously. My pet peeve is dilatant suspension. Take that medication and give it a vigorous shake for at least 30 seconds. Because if you just give it a shake or two, it's a thick, viscous suspension, and you do not mix it up properly if you don't shake it for at least 30 seconds. And if you don't do that, then the ramifications. You're not giving an adequate dosage. It's supposed to be 125 milligram per teaspoon, and if you don't shake it adequately, it's less than that. Then when you get to the bottom of your bottle on your dilantin, it's too thick, hard to shake, and the dosage is greater than 125 milligrams per teaspoon. Measuring of liquids in calibrated cups. If you have the 5, 10, 30 cc's calibrations that you're aware of on your little clear med cups, then it's no problem. The problem comes in when you have medication doses that are due in 7, 12, odd quantities that you don't have the calibrations for. The pharmacy should be sending syringes attached to that medication bottle wrapped with a rubber band so that you can use that syringe to adequately draw up that amount of medication. All right, medication is given per tube. This is the most difficult thing a med nurse has to do. All right, we're washing our hands with soap and water before and after. Okay, that's the third aspect of the 5 that I shared with you at the start of the talk. All right, you must wash your hands before and at the end of the tube feedings. I've had 2 facilities get tags for infectious control because they did everything they were supposed to. Then they returned the privacy curtain to its position so the residents could communicate with one another. And lo and behold, they reached and touched that curtain after they washed their hands and went to the next resident, and the surveyors tagged them for infectious control. So let that be the last thing you do, is wash your hands with soap and water before you move on. All right, we've got our medicine set up, and the difference between a tube feeder and a non-tube feeder. A non-tube feeder has an esophagus that is so many millimeters in size and can handle a bolus of doses. And it's okay to mix the medications. In tube feedings, you're dealing with a Levine tube that's 16 French or 18 French in calibrations. Therefore, we have to keep all of the medications separate. We can crush them, we open the capsules using gloves and keep them in separate containers. And then we get everything together, get our stethoscope and all of our equipment we need for this tube feeding, carry it into the room, get proper barriers, paper towels, Kleenexes or whatever, to lay the objects that we're going to be using during this tube feeding process down. Do not lay it on a direct surface. That's another infectious control violation. Okay, then when we get ready to go, we're going to check that tube for placement. We do that by 2 methods. The first is check for residual. We do that by pulling back on the syringe that we've attached to the tube, either the NG tube or the PEG tube, and pull it back and check for residual. And sometimes you don't necessarily have a residual, but if you do have a residual, you record the amount of the contents. Okay, then you detach that piston from that syringe and you lay that piston on that barrier I just explained. Then lo and behold, you proceed to flush it, with 30 cc's of air. And that pushes any contents in that tube that you cannot see back into the tummy of the resident. Okay? Then once we've checked for placement and all's clear, we're ready to go. And we start with the thinnest product and go to the thickest. And we can pre-dilute each medication in its separate cup with 5 to 10 cc's of water. But before we do that, we're going to flush that tube out to make sure it's all clear with one other step, and that's with 30 cc's of water. Now, if your policy and procedure varies from what I'm telling you on these quantities, you follow it to a T, because the surveyors will go back and check for your policies and procedures and compare them to what you're actually doing. But the rule of thumb is a minimum of 30 cc's to flush that tube. And you use gravity. Always use gravity. Never inject with that piston. And you use gravity and you let it go. And if it doesn't go, then you swirl that syringe like a tornado swirling motion. And then as last resort, you can get that piston off of that barrier and use the rubber stopper to scoop and bump that. Just get a little pressure gradient in that syringe so that it'll push it through gradually. And it will work, I promise you. Okay? If you have a difficult tube feeder that you know is going to stop up, pick another one, because the surveyors ask for that as one of the 5 things they want to observe during the mid-path. So pick the easiest tube feeder you've got in the facility. And then go get the surveyors, when you're ready to do it. Okay? Then we start with the thinnest, as I said, and go to thickest, administering 1 medication at a time. Put about 5 to 10 cc's more water in that cup. So swirl it around and rinse it to get as much as we can out so we won't get cited for inadequate dosage. Stack your cups up as you add them individually, and then after you give your last medication, you flush all that into the stomach. You don't want it adhering to the tube where it don't get absorbed. So you use another 30 cc's, or according to your policy and procedure, whatever amount it says, and you flush that in there. And then once that's done, you are finished, and then you restart the tube feeding, or if it's a G tube, you don't have that step to worry about. Then you lay that piston and syringe on that barrier again, and then you go about wrapping up your procedure. Then you go and carry that piston and syringe, under normal circumstances, into the bathroom and wash it rinse it and dry it to its best ability, and put it back in its bag with the tips down. During the mid-pass procedure, under the observance of a surveyor, you will be allowed to throw that piston and syringe away. That'll save you 3 to 5 minutes of time of rinsing and doing all that stuff. And I've checked with all the administrators in my facilities, and they will allow you to discard that to save time and save the risk of another infectious control procedure. So that's the tube feeding in a nutshell. There's several steps to it, so be careful. Next step, administration of medications and metered dose inhalers. Okay, metered dose inhalers is one of the few items that we do not have to wash our hands before and after. Okay, like we do on eye drops and on the tube feeders, etc. But there's some picky situations that you need to observe. If you've got 1 puff of 1 inhaler, no problem. If you've got 2 puffs of 1 inhaler, you separate each puff by a full minute. That allows them time to expand and let their alveoli sacs in their lungs to expand to the greatest surface area before each dose. And if you've got 2 different medications of inhalers, we pause a full 3 minutes in between. And in inhalers, there's a distinct order we give them in. If you've got 2 inhalers, one of them's going to be a bronchodilator and the other one's going to be a steroid. We always want to give that steroid last because it has propellants in it that coat them alveoli sacs in the lungs and make them long-acting. And so coating that, if you administer that inhaler first, the bronchodilator then cannot penetrate that membrane and that coating that's been administered on the sacs in the lungs. Then we move about our business, and if you have a steroid inhaler, the last step that you do, you encourage them to rinse their mouth with water, because those same propellants that coat the alveoli sacs in the lungs will coat the olfactory taste buds in the back of the tongue, and they will numb them up after a couple of days, and they lose their taste. They lose the taste, then it goes down the road. They lose their appetite. When they lose their appetite, they start losing weight, and the dietary is chasing rabbits trying to figure out why the resident's losing weight, and it's usually because of the steroid inhaler. All right, now we're going to move on to the eye preps. Eye drops must be treated with the infectious control precautions of washing our hands with soap and water before and after. And it's not in the regulations, but I hear it soon to be, and I advise you, if you have an infection in the eye, you need to wash your hands between each eye. But that's not in the regulations yet, but just get in the habit of doing that, because that keeps that infection from being spread to eye, and it protects you. Conjunctivitis, old-timey name for that, pink eye, is highly contagious and you can catch it easily. So we recommend using gloves, and then we recommend, that you wash your hands between the eyes. Okay, on the eye medications, if you've got 1 drop of 1 eye prep, it's no problem. If you've got 2 drops of the same eye prep, you're pausing a full minute in between to let it get absorbed. The lateral duct in the eye is very hard-headed, and it don't want to take but 1 at a time. And if you give them too close, back to back, what'll happen is that second drop will push that first drop out before it's had time to be absorbed. So pause, a full minute in between 2 drops of the same med. And then if you've got 2 different medications, you pause a full 3 minutes in between. If you've got PO meds and eye drops to give, I recommend washing with soap and water, administering that first eye prep, come back, set up your PO meds, because you're not going to do that within 3 minutes. Go administer them, then go wash your hands with soap and water again, come back and get that second eye drop, administer it, and then go to the next step. And then, of course, after each one of these steps, we must chart on that EMAR or the written MAR before you move on. Okay, now wrapping it up, dating of insulin vials. Most of them say 28 days. Some of the newer ones say 42 days. I've had discussions this past 2 months with some of my facilities, and they are changing their policies and procedures to match what the manufacturer's recommendation. Some of these new longer acting insulins say 42 days. So follow the manufacturer's recommendation or your policy and procedure, and date and time those little stickers that the pharmacy supplies on the insulins, either the vials or the pens. Dating of topical patches, you need to record the time, and place. You should be able to have a place on your MAR to chart the positions at which you apply these patches, and you need to rotate them each time into a different area so that the adhesive on them patches will not irritate the skin of our elderly residents. And then finally, the PRN medications, proper charting and follow-ups. The PRN medications is things that gets us caught a lot of times. You got to do follow-ups. If a resident asks for a particular medication, you got to chart, what it's for, and then within 30 to 45 minutes, you got to come back and chart on that MAR or your EMAR exactly, the response and if it was effective, okay? So make sure you're following up on your PRNs. And I have a rule of thumb on the PRNs. If they're still on the chart and they're not given no more than 3 to 5 times a month, I will ask for them to be discontinued. If they're given more than 15 times a month, I will ask for them to be made routine, because if they're asking for them that often, they're either in pain or they're having severe constipation and they need something on a routine basis, for just a few weeks. Okay, remember, if you jotted down any notes or have any questions, write them down and get your DON to call me. And then finally, I want to go over those 5 aspects of hand washings again. Anytime you have direct contact with a resident or inanimate object, before and after eye drops, before and after tube feedings, before and after injections of any kind, and before and after treatments. And that's the one that really makes the sense the most, because you're dealing with wound care. And use gloves to protect yourself. On tube feeders, the gloves protect you from bodily fluids, and we have so many weird diseases nowadays. You want to protect yourself as much as possible. Always use gloves before and after injections of any kind. And please do not allow the residents to control you on those injections. They'll get in the habit of saying, hey, can I have my finger stick before I go to bingo or any other activity? And you'll get in the habit of that and let them come up and ask you for that when a surveyor's watching you, and you'll forget. And all that stuff has to be done within the privacy of the room, okay? If you just giving them a standard cup of PO meds, they can take it outside the privacy of their room, but you need to make sure, ask them the question, is it okay if I give you this medicine in front of other residents, particularly in a day room where they may be sitting with other residents? Well, that's all of my time, and I thank you. And remember, jot down your questions and have your director of nursing call me. Thank you.